I request the speaker to take the podium, and let me request Dr. Muthu Subramaniam to present a memento to the speaker and welcome her.
A very good morning to all the delegates. It's a pleasure to be here early in the morning as a first speaker, little that I realize. But I think it's a very apt decision on the organizers because among the diabetes patients around whom the Diabicon is today coined around, kidney is the first one that gives you the alarm that watch out how the complications are starting. Thank you. So it gives you the first sign. So it's like a wake-up call. So I think it's very apt that as a nephrologist I'm standing in front of you today to talk about the kidney problems in diabetes patients. So today, as the doctor has mentioned, I would like to start with a case presentation. Through the case, we will be discussing about the definition or the variations of the definition of diabetic nephropathy, early recognition of diabetic nephropathy. How do we recognize the diabetic kidney early on? What is the incidence and the rate of progression? Along every area, whatever new has come up, I will try and put it on. Importance of delaying the onset and progression of diabetic nephropathy, the burden of today, and the updated treatment options available as of now. The first case, or the case only we have a 55-year-old farmer with no complaints was asked to undergo a medical checkup by his son, who's just become a medical student. Very enthusiastically, he encouraged his father, which is what it should be these days. So, no complaints. The person has no complaints at all. Other than that, he smokes occasionally, physically active, working as a farmer. On examination, his blood pressures are 150 by 80. He weighs about 50 kilos. His eye examination and the rest of the physical examination are all normal. On his urine examination, which is a routine checkup, preliminary checkup, it showed 1+ albumin. His fasting blood sugar is 130. Postprandial blood sugar is 170. HbA1c is 7%. Urea is 45. Creatinine is 1.1 and cholesterol is 200. So, what do you think? Do you think he is a diabetic? Absolutely. Okay, great. I mean, I'm sure you are the experts in this. I have no other question on that issue. So, how do you all think that he has a kidney disease? It's possible. You don't agree with that? Oh. Sorry? Possible. Why do we say possible and not confirmedly saying yes? What is it that is stopping us from saying that it is only possible and not agreeing that yes, he has it? Absolutely. Yes. Okay. Okay. I understand what you're trying to say is that all this hyperfiltration happens before the kidney problem develops in a diabetic. Agreed with that, but unfortunately none of them are visible to us. It's all microscopic. So how do we put the clinical practice ahead with the knowledge that we have from the theory? And that's what we will try and do today. So that is because we're unable to see that, we cannot say that it is not there. So we'll have to pick up the clinical science to help us guide that. So now looking at it, what are the ways that we can say the patient has a kidney problem or not? What do you think? One is a urine. Okay, urine is like the mirror of the kidney function. It tells us anything that is happening on early. Very easy to do. Okay, gives out a lot of information, which even a master checkup doesn't give. Okay, so that is the first thing to do. I'll elaborate on that a little bit more. So in our patient, he has an albumin of 1+ on a urine. What does this mean? Something abnormal? Agree? So one marker of the kidney, urine is abnormal. Second marker of the kidney, creatinine. Do you think that is abnormal, 1.1 for a 55-year-old male who is weighing about 50 kilos? You think it's normal? Absolutely, you think so, because the lab gives us the value saying that what is the upper limit? Up to 1.5. Some labs give us from 0.5 to 1.2. Some of them give it as 0.6 to about 1.5. Okay, however, let us see, is that true or not? Okay, let me walk you down. So, in this patient, every one of you agree that this patient is having an abnormal urine analysis, right? So, why do we say that? Is because the patient is having 1 plus protein. What does it in reality mean? As sir was mentioning here, after diabetes, that is in type 1, as you mentioned, a few years later, because all the studies we know is from the type 1 that we are putting on to the type 2 also, extending it on to the type 2. Type 1 we know exactly when it is started. So in the type 1 patients, after a few years, that is after minimum after 5 years, if they are in good control, or if they are not in that great of a control after 10 to 15 years any time, then they would start leaking protein as a first sign. So when the protein leakage, normal is about, albumin we are talking about, the leakage is going to be less than 30 is normal. However, when it is more than 30 to 300, we say it is microalbumin. What does the microalbumin define? It's basically that on the dipstick, on the routine urine which is done by a dipstick, if that dipstick is picking up, it is already a macroalbumin, meaning it is more than 300. Micro meaning the capacity of the dipstick is not, is only, the threshold is more than 300. So if it is not being picked up by the routine dipstick, it is a microalbumin. So 30 to 300 if you have a protein, that is microalbumin. Okay, so we know exactly that it will go from micro to the macroalbumin, the progression happens that way. However, in type 2 diabetics, we don't know the exact onset of the problem, when exactly the patient has started. So for this patient, what do you think, he has type 1 or type 2? Type 2. Do we know when exactly the diabetes has started in this patient? We don't know. So that's the case. So in such cases, because we don't know when it has started and it is a silent condition, we take it that the minute we see the protein, yes, the problem might have started. Okay, but the one glitch here, that not every time you have a protein positive, you should say he is already having a kidney problem, but you should be checking it once again, ensuring that it is a persistent proteinuria. Only then you say, yes, this patient has an abnormal protein. Okay, so rechecking is important. Documenting persistence is important. So what do you think now this patient has? Microalbumin or is it macroalbumin? Patient has 1 plus protein on the dipstick. What do you think? Absolutely, because it is more than 300 milligrams, we now call it as a macroalbumin. So what is, I mean, you might be confused with what is albumin to creatinine ratio or a protein to creatinine ratio that people keep on using. Any doubts in that? Okay. Usually when we are talking about microalbumin, we try and do the albumin to creatinine ratio. Okay, when we are saying 30 to 300, it is per day loss. Majority of the times it is not possible to collect the 24-hour urine all the time and confirm that. As a result, what we do is we do an early morning specimen, or a same time the specimen is checked repeatedly to check the protein to creatinine ratio. It's because the creatinine and the protein both are adjusted. If the patient is passing a concentrated urine or a dilute urine, both are affected. So it gives us an estimate, it gives us a relatively fixed estimate. Therefore, we use that for a convenience sake. So for a microalbumin, we use an albumin to creatinine ratio. But the minute it is more than 300, we can even say that as a protein to creatinine ratio. So that's the only difference. Okay. So always the gold standard is to confirm it with a 24-hour urine. But for a follow-up, it definitely helps. Now the second way we know that the patient has a kidney problem or not, the way we look at it is by the kidney, the creatinine. So this patient has about 1.1 creatinine and a urea of 45. So you all think because the creatinine is in the normal range, you are thinking he has a kidney function, normal kidney function. However, I seem to disagree with that. So let's see why. That's mainly because if we have an understanding about the relation between a creatinine and a GFR, it will show us why it is abnormal. As you can see here, if a creatinine is 1 in an individual as a baseline and it is representing a kidney function which is normal, which is about 100%. Percent I mean, I'm not talking about ml per minute. So if 1 is equal to 100% of the kidney function, by the time the creatinine has raised to 2, the GFR has gone down to 60. Okay, so this is where the importance lies. Creatinine is a very late sign of a kidney function. GFR, as everybody knows, so creatinine does not mean, normal creatinine does not mean normal kidney function, meaning not a normal GFR. A simple rule is that if the creatinine is doubling from 1 to 2, the GFR is dropped by 50%. If the creatinine is raising from 2, if the creatinine is raising from 2 to 4, you have another 50% reduction, that is 60 has come down to 30 ml. So majority of the times patients are referred to us over here and they keep saying that, array, we have a sudden jump in the kidney creatinine. Actually, the sudden jump here from 4 to 8 only means that you have lost about 15% of your kidney function. Whereas the creatinine jump from 1 to 2, you have lost 50% of the kidney function. So it's important to understand that the creatinine is a late sign. By the time you pick up on it, the patient is already in stage 3. So in India, the values are not supposed to be used as a baseline values anymore. So please don't use them at all. But try and calculate the GFR in those patients using a simple table, at the consultation table methods. And those are by the Cockcroft and Gault formula, which means a formula I'm giving it to you a little later, which is 140 minus the age in years times the weight of the patient in kilograms, divide the entire thing by a 72, a constant, and again divide that with the serum creatinine value of whatever the value is in milligrams per dl, will give you an estimate of a GFR of that individual. If it is a female, multiply that with 0.85. Basically, it is adjusting to the weight, which is a muscle mass, from a male to a female, and will give you a GFR estimation of that lady. MDRD formula uses, in addition to this, race and other things, little difficult to calculate, so we don't use it on a day-to-day basis, but you can use a computer to calculate that. Again, a gold standard is to measure the 24-hour urine to see the creatinine clearance. Okay. Majority of the times when we are talking about a creatinine clearance, several times the way to collect the urine is very, very important. We ask the patient to first pass the urine, wake up in the morning, throw the urine out. As they come out of the bathroom, note down the timing. From that means starting with an empty bladder. From that time onwards, every single drop of urine that they are going to make during the day and night will be collected in the can that is provided to them. Till the next day, the same time that they have to collect the urine, the time that they have noted, if it is 6:15, 6:20, they have to collect it again at that time into the can, close it, come to the lab and give the creatinine blood testing along with the lab. So that helps us in measuring the creatinine clearance and confirming whatever we are estimating on the Cockcroft and Gault formula. Okay, and several times we find a lot of discrepancy between the measurement and what we are estimating. Okay, there are pitfalls for everything, but if the urine is collected properly, then that is the way we have to go with. And how do we know that the urine that is collected is appropriately collected and that value has to be taken into consideration? The way to know that is if you see the 24-hour creatinine in the total amount of creatinine in the 24-hour urine, and if that is, like the patient's weight is here 55 kilos. So if that times 15 kilos, 15 is the amount of creatinine that you expect per kilogram. 55 times 15 is the amount of the creatinine that is there in the 24-hour urine, then that urine is valid. So then we go with that value. So that is how we double check that. So there are many other ways of picking up the kidney function early before the creatinine. And those are, today's day the thing is cystatin C. What is cystatin C? It is an end product and it is produced by every cell that has a nucleus, and it is excreted through the kidney only, and it is not reabsorbed through the kidney. So it becomes a better marker than the creatinine for an early detection, and the values are between 0.5 to 1.2. However, it is very difficult assay to do, very expensive assay to do, and not that it is adding too much to our mode of treatment. Therefore, as of now, it is not very well known or very predominant here. The other exogenous markers, which we call again as a gold standards, are the inulin clearances, again very difficult to do. In US and all, we were doing the isothalamate radionuclide clearances. That is an easy way of doing, but again very expensive, not standardized here, so I didn't get to do that anyway here. So, do you agree that our patient has it or not? So let's put that into the formula and see. 140 minus his age, that's his age, times the 50, divided by 72 and the creatinine value. And because it's a male, I'm not multiplying with 0.85. So his creatinine clearances are coming up to 53 ml per minute. Now do you agree that this patient has a kidney problem or not? Yes? I don't think everybody is convinced here. Not convinced? Huh? Yeah, please. So 53 ml is definitely lower. Okay, so by the time the creatinine has raised, see at 50 kilo, a farmer, not very physically fit probably, or maybe not much of a muscular mass. So in him, his baseline creatinine is only 0.6. So if the 0.6 has now come up to 1.2, so we are really missing that. The 50% is lost before even he is crossing that upper limit of the thing that is mentioned in our labs. So please be sensitive with this, that's all. And in him we also confirmed the creatinine clearances on a 24-hour urine, confirmed that it is about 50 ml per minute. On a radionuclide scan, DTPA that was done, it is again 60 ml per minute. We don't do it on a routine basis, but it can be done, that's all it shows. So take home value is creatinine within normal limits does not mean a normal renal function. Creatinine is not a good marker for the early kidney disease, and cystatin can be used, however not yet prevalent. Okay, so please use the formula bedside. Now let us see what is the stage of, we agree now that he is a diabetic, he is a type 2 diabetic, he has a kidney problem by the means of protein, which is a macro protein, and he is also having a kidney problem by the ways of a creatinine of 1.1. Now summarize that. What stage do you think he is in? Stage 3. Okay, so basically with the way of GFR, we label it as more than 90, stage 1, 60 to 90 is stage 2, moderate, that stage 3 is between 30 and 60, stage 4 is 15 to 29. All of them are called as kidney disease states. The minute the GFR is lower, below 15, we call it a kidney failure. Okay, and if it is happening on a gradual basis, then we call it a chronic. If it is sudden, it's acute. It is acutely done on a chronic patient, it is acute on chronic. So the definition of a chronic kidney problem is that either a kidney damage or even an ultrasound, if you have abnormality, urine abnormality, or the GFR that is calculated less than 60%, any of them for more than 3 months, you call it a CRF. So coming back to our case again, do you think, we know he has a kidney problem. Now do you think that this patient is having a diabetic kidney disease or not? What do you think? You think he has a diabetic kidney disease? Yes? You don't think so? Okay. What makes you not think so, please? Retinopathy is not there, absolutely. Okay. Right. That is a common understanding. So let us see if that is really true or not, okay? And is the protein in the urine, one more thing I want to ask you, protein in the urine in this patient, is that happens only in the diabetic nephropathy or any other diseases also? It can happen with none, right? All of us agree on that, right? So let us see the definition of the diabetic nephropathy as of today. That is, glomerulopathy or diabetic glomerulopathy is defined as a characteristic structural changes, as has mentioned, mesangial expansion, glomerular basement membrane thickening, and a glomerulosclerosis. Functionally, we see hyperfiltration leading on to albumin loss in the urine. Clinically, we see a persistent albuminuria, sometimes hematuria as well, with a progressive kidney disease over few years. In the presence of a diabetic retinopathy and in the absence of any other conditions causing a kidney problem in the form of labs or abnormal clinical features. However, so according to this definition, I agree with you that it is not a diabetic. However, the relation between, okay, I'll come to that. The relation between the retinopathy and proteinuria. There's a study done in Kidney International wherein 347 diabetic patients were taken with the proteinuria. So similar to our cases, and in 93 of them, they did not have a retinopathy. And among the 93, 53 of them were taken for a kidney biopsy, just to see what is happening. And in them, 35 patients had a diabetic glomerular disease, and 17%, that is up to 31% of them had a non-diabetic or a non-glomerular diabetic renal disease. So what is this telling us? That yes, it is important that they should have a retinopathy in type 2 diabetes, when we can say yes, the proteinuria in this patient also has retinopathy, so most probably diabetic nephropathy. However, absence of retinopathy does not mean the patient does not have a diabetic nephropathy. But there is also high likelihood that they could be having a non-diabetic nephropathy as well. So we have to start looking for those signs. It could be hypertension, absolutely. It could be a hypertensive glomerulosclerosis, age-related glomerulosclerosis. It could be atherosclerosis. A lot of other things can come up. So what are the clues to say that it's a non-diabetic glomerular disease? If a patient has a proteinuria, in a type 1 it is very easy because you know exactly when it is starting. If the proteinuria is starting before 5 years of the onset of the type 1, then you know it should be not diabetic related but non-diabetic. Also, lack of retinopathy or neuropathy in type 1 at the time of proteinuria tells you yes, non-diabetic. However, in type 2 problems, the acute onset of a renal disease, diabetic nephropathy is abnormal. Diabetes progresses very slowly. However, if it starts acutely, suspect non-diabetic. Presence of an active urine sediment with red cells. Very rarely you can see red cell cas even in a diabetic. However, the presence of that, start thinking maybe it is not diabetic. Signs and symptoms of any other systemic problems, skin rash, joint problems, not feeling very well, body aches, all of that. Or if there is a significant reduction in the glomerular filtration rate, that is up to more than 30% within 2 to 3 months of starting the ACE inhibitor, is an indication or a sign that it may not be a diabetic related nephropathy. So we should think about a kidney biopsy. And this is the times when several times we are referring them for a biopsy, but they go back to the primary care and they said, no, you have diabetes and it must be because of diabetic nephropathy, don't go for biopsy. Okay, so please think about it, that 31% of these patients can have a non-diabetic nephropathy, so renal biopsy may become necessary. So the incidence of how many of them do really develop this nephropathy? In type 1, about 20 to 30% of them develop a macroproteinuria, but half of them progress to kidney chronic renal failure. In olden days, the incidence used to be 45% of them would develop over proteinuria, and 16% of them within 30 years would develop end-stage renal disease, which has now come down with all the efforts of the diabetologist, bringing the diabetes in control, paying more attention towards the hypertension and controlling the protein loss. Type 2 and type 1 almost follow the similar thing. It's just that in type 2 we don't know when it is starting. And usually the time frame that we can say is if nothing is intervened, patient once they develop protein loss, like our patient, he could go in and develop an end-stage kidney problem within 7 to 10 years. But if we intervene, we can delay it a lot. If the creatinine is already 2, then he would progress to dialysis within 2.5 years. So it's important that we recognize very early. As you know, the risk factor for the progression is, as you can see the redness here, the green is better, and the rapidity of progression is more as the color is indicating. So protein loss and the GFR calculation is important. GFR estimation, as you all know, is not the is the only way, because creatinine is not the best way of identifying it. As I said, cystatin C may come up down the road. It is available even today, but it is expensive. So proteinuria, as everybody knows, what is the importance of identifying this early is because the microproteinuria is the only stage that is reversible. And macroproteinuria, the onset is the time when the BP starts. A diabetic patient starting to have a hypertension is the onset, marks the onset of protein loss. Okay, so from here, probably we are not able to reverse it from the macroalbumin, but we can delay the progression. If we don't do it, approximately 5% decline in the GFR can happen. More than 50% decrease, if at all on treatment, the proteinuria decreases by 50%, then we can delay the all-cause mortality and the kidney failures as well. So response to treatment also tells the prognosis in that patient. Proteinuria is a marker of the endothelial lining damage. So that is why it is showing through the kidney, which has a lot of endothelial lining in the glomerulus. So it's an early sign to be picked up. Importance of early detection is because it's very common, it's very harmful, but yet treatable. Early detection and monitoring can delay the onset of the staging, kidney worsening, and also the dialysis. It is a disease multiplier, kidney disease. It increases the heart disease as well as the mortality. Once the patient is on dialysis, they'll require at least 20,000 rupees a month, and we cannot afford that. Even on transplantation, minimum, the amount multiplies, and throughout their life, they'll have to spend about 15 to 10,000 rupees a month. So it is a very time-consuming, emotionally draining, and financially taxing. Nobody can afford kidney problem for a long time. If you treat them early, it can definitely give you an acceptable quality and quantity of life if we are preparing them very well. So a lot of things to do. Also that not only if we identify them, diabetics especially don't do very well even on dialysis. After the 36 months, as you can see, the diabetics mortality rate is much higher when compared to the non-diabetics. So more so, very important that we identify them early and prevent it. The treatment options that we have as of today, this is something that you all already know of. That is diabetes, excellent diabetes control, and the role of PPAR gamma agonists, that is pioglitazone and rosiglitazone, although they are now taken off the market, if they are tolerating, pioglitazone is still a good one. It decreases the proteinuria and also helps in the GFR maintenance very long. Just like metformin, which was taken away from the market and came back, who knows, sometime down the road we may come back with pioglitazone again, because it does have its positive effects on the kidney. The hypertension control, very, very important. So in our patient, in addition to controlling his diabetes, please focus on the hypertension control. And the goal for hypertension is, as the proteinuria has started, meaning an end organ damage has started, our goal for BP is about 130 systolic and 80 diastolic. But please take it, not one size fits for all. If it's an elderly patient or a cardiac patient, the goal is never going to be that strict. It has to be little above than that, never lower the diastolic below 70 in a cardiac patients, and the systolic below 110 is absolutely not acceptable. Coming to the protein reduction and the high BP control, choose the first drug of first line of agents, that is ACE inhibitors, which are proven in type 1. And it's not that the type 2s don't work, ARBs don't work, it's just that we have more studies in type 1s with ACE inhibitors and with the type 2s with ARBs. However, both ACE inhibitors as well as ARBs can be used in both. The protein restriction, this is a point of debate. In India, everybody seems to be put on a low protein diet. Please don't do that, because our Indian protein, the intake is not more than 1 milligram per kilogram. So by putting them on a protein restriction, we are not really achieving anything. We are making the patients lose their muscle mass, and it is not the priority. But if the patients are loading themselves with the protein supplements, that not allowed. That's all. And weight reduction, yes, higher the weight, higher the BMI, which our patient does not have, is also can contribute to glomerulosclerosis, so that also has to be paid attention to. Cholesterol control with an LDL levels of less than 100 is recommended. Smoking cessation, there's no doubt in that, I guess. So the new thing that came up is a vitamin D supplementation and a role of vitamin D in preventing or delaying the proteinuria and the diabetic nephropathy. I'll talk about it a little.
And check his vitamin D levels and supplement that if needed. So I think the drugs, the first preferred drugs are ACE inhibitors and ARBs. Mind you, always a diabetic is having an underlying volume overload, so please use a diuretic. And chlorothalidone is preferred when compared to hydrochlorothiazide only because of the longer duration and more effective with less lipid problems. And the second drugs that are known to be protective from the kidney angle is also diltiazem and verapamil. And amlodipine is not bad. When you cannot use diltiazem, please go ahead with amlodipine and other medications. Do not use diltiazem and metoprolol because they both have the negative chronicity, the pumping action on the heart. And do not use ACE inhibitor and ARB together. Anytime you're using ACE inhibitor and ARB, please do one thing, that is encourage them to restrict their salt, because only by restricting the salt, the effect of the medicine is multiplied. And the second thing is that all diabetics have a tendency to retain potassium in their body. By putting them on an ACE inhibitor, we may increase their potassium retention, which can lead to emergencies. So anytime you put them on a medication, please check their potassium 3 to 5 days from the day of starting it. Then coming to the proteinuria, our aim is to lower it. The medications that are proven to lower the proteinuria are ACE inhibitors, ARBs, aliskiren, aldactone, eplerenone. All of them lower the potassium. All of these medicines are acting on the RAS, renin-angiotensin system area. Other medications are diltiazem and verapamil and low salt diet. A lot of research has been going on in this RAC and also the cytokines that are being produced, inflammatory markers that are being produced, and all the other things that are being under workup as of today are pentoxifylline, protein kinase C inhibitor, fenofibrate, fish oil, endothelin receptor antagonist, and psilodexide. However, none of them are so far standing to the test that we can use them, not yet to the clinical practice. Diabetes, you know this already. I think I'm running too much out of time. Let me know. Okay, regarding the protein restriction.
Already 30 minutes over, madam.
Over. Sorry. Okay. Let me quickly run down. This study is actually telling us that, by putting them on a protein restriction, we are losing muscle. It's not contributing to GFR protection at all. This is the vitamin D role. It is proven that it is not harmful, at least in patients who have vitamin D less than 15. Then they had a progression of the proteinuria, progression of the kidney failure, and also all-cause mortality was high. So we should check it and replete it. And I think you all know. In the new thing in the pathogenesis that we are talking today is the podocyte-specific insulin receptor. Okay, we seem to be finding that that is the problem where we can address. The lot of studies are again going on. Nothing as of today has come up. In the emerging therapies, I said all these things. However, none of them are standing. Two things to note: atrasentan reduce the protein loss, paricalcitol reduce the protein loss, pirfenidone and bardoxolone, they all increase the GFR. However, they are very harmful. We know the studies on bardoxolone, although it is increasing the GFR, it is causing cardiac problems and having early mortality. So they are not beneficial, but they are harmful. So we have to avoid these combinations. One size doesn't fit for all. So just to get another opinion and understand where we are doing, so a nephrologist can be consulted. What are the timings at the time of onset of hypertension or protein loss or proteinuria in any diabetic patient, to know the etiology, to set the goals, and to educate a possible end organ damage, saves time to the primary care, and the frequency of visit only twice in a year is good enough. If any patient with an active urine sediment or symptoms of vasculitis or recurrent UTI deserves a nephrology consultation once. At all levels of CKD, estimate levels, the stages are told to the patient, given education in the first thing. Early referrals will definitely do a lot of benefit to the patient. They delay the progression efficiently, and also by making the patient become a partner in their own health care, and identify their cardiac risk factors and prepare them early if they have to go on for dialysis. So it's time to do a teamwork. Sorry for taking a long time.
That was a phenomenal lecture by Dr. Saritha. Any doubts? The floor is open for interaction.
So, madam, as a treating physician, practicing physician, we find a problem, the diabetes nephropathy, especially when there is a massive proteinuria.
More than 3 grams.
Yeah, more than 3 grams in a normotensive or slightly hypotensive state. So, in those situations, whether to use ARBs, where BP is low, 90/60, where proteinuria is massive and diabetes is under control. So, how to manage such situation? That's something we commonly face a problem. The rest of things are routine. We don't have any problem at all.
Absolutely.
Right. Thank you.
Yeah, the massive proteinuria, that is more than 3 grams, these are the people who are going to progress much faster. So it is not just the protein loss, it is not just the BP, but it's a multifactorial that we have to look at. So coming only to this hypertension and the protein thing, today's day we have the ARBs, among which the repace is not as good as an antihypertensive agent, but it's a good antiproteinuric effect. So we use that kind of medications, losartans, and give it twice a day or something if the BP is a problem. Majority of the times, if the BP is a problem, also look at the cardiac problem. Maybe cardiac is already involved, wherein the ejection fraction is low and we are having a low BPs. Yeah. The BPs are low. See, what is stopping you from treating the proteinuria with an ACE inhibitor? The low BPs. So the low BPs, look at the etiology of that as well. If you are using a diuretic and an ACE inhibitor, then maybe sometimes both of them together can cause a low BPs. So start one at a time. Start with the medications that are less antihypertensive but having equal antiproteinuric effect. So this is the way I go with it, and always watching the side effects. If the side effects are there, then you better not progress it too fast. Yeah.
Good morning, madam. My question regarding treatment option, ma'am. What about the role of Nephrosev in treatment option?
Role of Nephrosev. Nephrosev is like this pentoxify and another thing. It is only an antioxidant. But unlike pentoxify, when the side effects are noted, with this one we don't have a side effects. And there is no definitive proven benefit. However, the side effects are not there, so we are using it.
One more question, ma'am. Regarding the statin dosage on dialysis patient.
Regarding what?
Dosage of the statin on dialysis patient.
Statin on dialysis patients. Okay. Usually, it is proven that only in CKD stages up to 4, the statins have a role, and they have shown to decrease the mortality and all-cause cardiac problems as well. But once the patient starts on dialysis, there is no document of statins noted. It is equal to that of a placebo. However, when you already have one cardiac event, they are giving it. It's only when they have an acute MI, they're giving an 80 milligrams dose. A short time 80 milligram dose is okay, but not on a long-term basis. Then we come down to about maximum about 5 to 10 milligrams, which is adequately, is good enough.
Whether end-stage renal disease, we can do CT scan for the diagnosis of morphological changes, any morphological changes in CT scan.
See, morphological changes of the kidney or some other?
Kidneys.
How does it matter? Once the patient, when you say ESRD, that's a dialysis patient already, right? So such a patient, what are we going to achieve by doing a CT scan on him? However, if you, let me change that question a little bit. If you're saying that a scan is required in a dialysis patient, like for any other abdominal problems that you're wanting to do it, compared to MRI scan, CT is better and safer. Why? Because any patient with this ESRD and they get an MRI contrast, that can cause lot of abdominal fibrosis problems. Therefore, we don't go for an MRI scan, but we go for a CT. But we plan it and time it with the dialysis. We do the procedure just before the dialysis, and the patient is moved on to the dialysis following the procedure, wherein the contrast can be removed, because the contrast can cause two things. That is a volume overload, and next is a neurotoxicity. So for both the things, we do the dialysis immediately following the procedure. Timing has to be done, that's all.
Thank you very much. That was a phenomenal and excellent, very useful lecture to the practicing physicians. Thank you very much, madam. Congratulations.
Thank you.
And I now request Dr. Vijay Rani to present a photograph, the hot shot photograph to the speaker. Thank you, Dr. Vijay Rani.